All right, well, thanks for having me. My name is Jeff Rudy. I'm a neuroradiologist at Scripps Health in San Diego. And I also have an adjunct appointment at UC San Diego, where I do research. And most of my research actually is in brain tumor research, neuro-oncology, brain metastases, diffuse gliomas. And I've been involved in the Brain Tumor Segmentation Challenge since about 2018. One of my colleagues at Penn, who was organizing it, Spiros Bakas, as a resident, walked over there and just to his lab and started helping him out, annotating cases and getting more involved. And then it became a bigger challenge in 2021, where it was an RSNA challenge, and we had a lot more teams competing. And then actually this past year, so previously it was always a pre-treatment glioma, but then last year we had finally the first year, the 2024 challenge was post-treatment glioma. And this kind of happened sort of in parallel to me starting to work at Cortex and advise them on developing a brain tumor segmentation product. So I'm going to talk about NeuroQuant Brain Tumor, how it works, and a little bit of the research behind the development of the algorithm, and then some of the work that I did at UCSD with Cortex through the SBIR grant using restriction spectrum imaging. And then the second part of my talk is going to be about NeuroAlign CT. So at Scripps we use it, and we're a big trauma center, big stroke center. So I use it all pretty much every day, multiple times, and I'll just kind of show you some of the use cases and how it works. So there's just a little bit of background about Cortex. 15 years of proven leadership, of 1 million brain scans processed. It's an MRI vendor and PACS agnostic system, and has been FDA cleared and approved for segmentation in ages 3 to 100. Okay, so NeuroQuant Brain Tumor, just some highlights. So this is an FDA cleared product for brain tumor segmentation and longitudinal volumetrics. It works for both high and low grade gliomas, and it works on both pre and post treatment MRIs. And that's just kind of a highlight of the outputs of the system, and I'll go into more detail. But you get this segmentation overlay. It's sent into your PACS on DICOMs delivered to your PACS, so you can review the segmentation outputs. You get the PDF of sort of the most important information about the brain tumor and the longitudinal aspects of the different volumes, the different tissue classes. And it also outputs a RT struct file, which you can manipulate if your PACS allows you to manipulate RT structs. But importantly, you can also import it into radiation treatment planning software to use it for treatment. So just kind of an overview of how it works. The patients are scanned. The inputs into the sequence, as have been used in prior research pipelines and are needed for different aspects of the segmentation, are the T1 pre-contrast, T1 post-contrast, T2, and the flare. So those are acquired from the scanner. They're sent to the PACS, and at the same time, they're sent to the CTX node, the DICOM router, which is then processed the AWS cloud. And then from the AWS cloud, the data is sent back to have your segmentation overlays, your RT struct files, and your PDF reports, which can then be viewed as you're viewing the original images themselves. So this is just an example of the tissue classes that are outputted as part of this. And this is an example of a high-grade glioma. You have the enhancing tissue, kind of like the core portion of the tumor, which typically is resected. You have the central non-enhancing necrotic core, and then you have the surrounding T2 flare hyperintensity, which can represent a mix of infiltrating tumor and edema. So here's an example of the same patient where we have the preoperative segmentation, and then 3 months post-operative. And here, in this case, we have an additional category here, the resection cavity. So you can measure the resection cavity and all these other classes kind of over time. Here's just a couple more examples of cases with resection cavities and different tissue classes in the post-treatment setting. And as I mentioned, it works on low-grade gliomas, and typically low-grade gliomas don't have any enhancement, so you just really have this flare hyperintensity, typically just this segmentation mask. So this is just some details about how we trained the model for the NeuroQuant Brain Tumor. We took MRIs from both the Brain Tumor Segmentation Challenge and the Cancer Imaging Archives, about 650 MRIs across over 50 different institutions, get a mix of preoperative and postoperative and then they were stratified by grade, operative status, and put into train and test. And we use the NNUNet architecture for model training and development. So these are results from the initial results that were presented as an abstract at Society for Neuro-Oncology. Just to give you a little more context, so what these scores are, these are DICE scores. DICE scores basically are one of the ways, probably the most important ways of evaluating the performance of a segmentation algorithm. It looks at the overlap between the ground truth masks and the predicted masks. So you basically ignore true negatives, all the kind of the background. So DICE scores, we're getting DICE scores of 0.89 to 0.94 for preoperative, 0.8 to 0.93 for postoperative. A DICE score above 0.8 is very good. Above 0.9 is excellent. So the DICE scores are very good. Interestingly, and I'd seen this before, you do generally have slightly better DICE scores for preoperative. In the post-treatment setting, cases can get a bit more challenging, a little messier, harder to distinguish what's post-treatment changes. But that was not really unexpected. Then you can also look at a correlation, a Pearson correlation, or Spearman rank correlation between the total volumes between manual and ground truth, and you get a correlation of between 0.87 and 0.98 for these different categories. And we look again, they're separately looking at it for enhancing tissue, necrotic core, the surrounding flare hyperintensity, the resection cavity, and probably the two most important things that are involved in the assessment in neuro-oncology is that enhancing tissue volume, and then sort of the whole lesion, which will combine the enhancing tissue, necrotic core, and the flare hyperintensity, but not so much the resection cavity. So one of the things that I did with this data set, in addition for the NeuroQuant Brain Tumors, we took it a bit further because, as I mentioned with the brain tumor segmentation challenge, a lot of work had been done on pre-treatment MRI, and it was only relatively few studies have been done on post-treatment. So there was kind of an open question of whether it would be important to have a separate model for pre-treatment, a separate model for post-treatment. So what we did is we evaluated 3 different networks looking at training together all of the pre and post-treatment scans, and so that's the combined network. A network where you train just the pre, and a network you train just the post. Just to answer the question of, is it better to have 2 separate networks or a single combined network? And sorry, the results are very busy here. The paper is published in Neuro-Oncology Advances this year. But essentially what we found is that just a simple combined network did just as well as the pre-treatment network on the pre-treatment cases, and just as well as a post-treatment network on the post-treatment cases. And I think in some cases was even slightly better. So basically just it makes things a lot simpler to have a single network that can do pre and post-treatment. So here's an example of the PDF report that comes out that can be viewed, and you have the basic patient information, you have a sort of a cropped image, an axial slice centered on where the tumor is, with a different kind of tissue classes showing the T1 plus contrast and the flare. And then importantly, the longitudinal volume metrics, where you can look at the prior studies to see a kind of what the trend is over time. And again, the 2 most important things that we're looking at here is the enhancing tumor, and then sort of the whole lesion, which combines the enhancing tumor, the necrotic core, and the surrounding flare hyperintensity. And you also can get the actual volumes and the percent changes here as well. So as I mentioned before, there's you also get an output of this RT struct file, and this is something that can be output as an overlay, and depending on your packs, or you can actually modify it, and it can be used again for radiation treatment planning. So I just have a couple examples from UCSD. So I'm clinically mostly at Scripps, but my research is at UCSD, but these were shared by one of my colleagues, Nikki Fareed, because it is in deployment at UCSD, and it's soon to be deployed at Scripps. But this is just an example showing, kind of nicely showing with this longitudinal chart, how really there was, between these last 2 time points, a pretty significant increase in the volume of this enhancing tumor, 43% increase in size. So pretty clear case of the tumor progressing in between the last time point. But yeah, having these longitudinal maps give you a good sense of what's going on. And then here's another example where you can just kind of see over time the volume kind of just tracking down, which makes you a little more clear that the most likely this just represents post-treatment changes that are kind of involuting and going away. So in progress, one of the things that the standard of care for neuro-oncologists for treatment planning, for clinical trials is RANO, Response Assessment in Neuro-Oncology. And the way that they measure the tumors is by these kind of 2D dimensions, by measuring the maximal 2D dimensions and summing the products of the diameters. And that's what they generally use to make their cutoffs of whether the patient's progressed or not. And so although I believe that the true 3D volumetric information is going to be probably more accurate, more valuable, in order to kind of conform with how RANO and neuro-oncologists currently measure things, this has been going to be added very soon to the product to have these more standard longitudinal measurements using the sum of the products of the perpendicular diameters. There's also in progress the ability to track individual lesions. Some patients will have multifocal, multicentric disease, and so you want to be able to see whether each individual lesion might be changing over time. Also in the works and planned for development next year is expanding this from beyond neuroquant glioma into brain metastases and meningiomas. Similar sort of tools, similar sorts of measurements, but meningiomas actually are the most common types of central CNS neoplasms, and it's incredibly common that it is an outpatient setting that you'll be reading a follow-up, and you want to, the main purpose again is just to assess if there's any change or not. So having the automated volumetric measurements can really kind of easily help you be more efficient in making that assessment. And then brain metastases are also quite common. And the thing about brain metastases is that of course, can be multifocal. You can have 5, 10, 20, 30, 40 brain metastases. And so it can be challenging for the radiologist and the radiation oncologist to actually identify, measure, and assess changes for each of the brain metastases over time. As a neuroradiology fellow, that was one of the tasks that I did at UCSF. If it's just a routine assessment, you can kind of give a gestalt of how many lesions there are and if they're changed or not. But for patients that are undergoing radiation surgery, you have to be very precise in measuring every single lesion, identifying where the lesion is, and then that gets relayed to the radiation oncologist, who then actually does do a manual segmentation process for every single brain metastases while they're being treated. So really, I think there's a lot of potential to facilitate workflows for radiologists and radiation oncologists by having a brain metastasis product. Okay, so I can move on into some of the work we did in RSI, and RSI is restriction spectrum imaging. So this is a advanced diffusion method, multi-shell, multi-B value acquisition. And what this does is by having a multi-shell and multi-direction, it allows you to quantitatively model different components of restricted versus hindered diffusion. So generally speaking, by separating spherically and cylindrically restricted diffusion, you can look at kind of what component of diffusion has to do with cell bodies versus axons, if you're looking at white matter tracks. So by separating those out, you can really get good signal for what we care about in diffuse gliomas, which is highly dense cell bodies. So by having these RSI maps, you can see that it really kind of brings out areas of tumor infiltration in highly cellular tumors. And so the RSI sequence is actually an exclusive sequence that's licensed by Cortex and through GE, but also available as sort of the version through Siemens. And that actually is part of the NeuroQuant Brain Tumor package and FDA clearance. But what I did at UCSD, I want to tell you a little more, is taking it the next step further. And sorry, just first a little bit of background. Prior to me going to UCSD, there was some work on RSI had been used in a few kind of case studies showing how it can be sensitive in detecting recurrent disease. Again, in the post-treatment setting, it can be challenging because you'll get areas of enhancement that are just related to post-treatment changes, whereas what we care about is whether there's recurrent or residual tumor. And this just kind of shows an example of where it did a decent job of detecting a recurrent tumor. It also, the RSI maps, even in areas of enhancement where the RSI is not bright, it has a pretty decent job or specificity of distinguishing treatment effects. Okay, so this is the research that was part of a SBIR grant that Cortex got that I was involved in. And the goals of this project were to be able to segment non-enhancing infiltrative tumor. Again, this can be challenging to distinguish infiltrative tumor from what's edema or post-treatment changes. And then also to distinguish enhancement that represents recurrent residual GBM from post-treatment changes. So sort of pseudoprogression. And then taking these maps of cellular tumor, the volumes of actual cellular tumor, and trying to predict survival. So at UCSD, we went through the records and collected all patients. And in this case, we use a variety of additional inputs rather than kind of your standard T1, T2, T1 post contrast and flare sequence. We added standard diffusion, SWAN SWI, pure fusion, CBV maps, and the RSI maps. We did standard sort of pre-processing, skull stripping, and registration. In this study, we had 184 cases at training, and then an internal and external cohorts for validation. And by the way, this was actually just published this year as well in Radiology AI. So then we trained an NN-UNet for cellular tumor segmentation to identify the areas of infiltrative cellular tumor, enhancing cellular tumor. And then the next step was also to predict outcomes. So here's just an example of some of the performance of using different inputs. So these, if you use your standard inputs that are used in most of the brain tumor segmentation challenges, we're getting a dice score about 0.65 to predict what cellular tumor was. If you add the perfusion map, you're only really slightly increased. But when you add this RSI cellularity map, is where you get the most increase in performance to really identify the areas of cellular tumor. Interestingly, if you don't have an RSI, but you have a standard diffusion, you add an ADC, you can bring back some of the performance there, because again, the RSI is just kind of a more advanced form of diffusion, but just a standard ADC, which is pretty much required in all brain MRIs, can be useful. So I'll just show you a few example cases, some of the inputs into the model. So this is what you would get from a traditional tumor segmentation map. Again, this class of surrounding non-enhancing flare hyperintensity is a little more broad. It includes edema. It includes post-treatment changes, because it can be very challenging to just really truly say what's infiltrating tumor, what's edema, what's post-treatment changes. So you kind of have to look at it as a whole. But by specifically training a model to look at cellular tumor, we're able to get this result instead. So we can see here that what's the cellular tumor is this enhancing cellular tumor. And then if we look back here, we can see that it's also teasing this part out as being cellular tumor. And it's actually not surprising if you go back to the original images, you can actually see here that you have this sort of intermediate T2 hyperintensity. Typically edema is very bright on flare, bright on T2. But you kind of get this intermediate signal and a little kind of mass-like signal here, where this, in fact, is infiltrating tumor across the corpus callosum. And so you can separate, based on these initial segmentation maps, what's the enhancing cellular tumor and what's the non-enhancing cellular tumor. And same thing if you go back to the RSI map and the CBV map, you can see same thing, that the RSI map is really kind of bright, where this infiltrating tumor is extending across the corpus callosum, and the CBV map is also bright. There's a lot of blood flow going there. Okay, here's a case where we have this kind of nodule enhancement in the left occipital lobe. There's surrounding T2 flare hyperintensity. This is kind of what you're going to get with your tumor segmentation model. And not surprising, you have this enhancing, you have the T2 flare hyperintensity. But what do you get with the cellular tumor model? Well, actually nothing here, and this actually turned out to be a case of pseudoprogression. So in some cases, the patients will get treated for temozolomide and radiation, and the brain will become inflamed as sort of an inflammatory response. But knowing that it's actually just a case of pseudoprogression is quite useful for preventing the patient from going back and getting more surgery. And so you can if you go back to the original data itself, you can see that the RSI map, it's not cellular, there's not a lot of blood perfusion. So if you're really trying to only actually predict areas of true cellular tumor, this model was able to distinguish that. We took this kind of a next step in patients where we had an MRI that was a certain time period after surgery. We tried to look at their overall survival and their progression-free survival. And we found that the volumes of cellular tumor were actually significant predictors of overall survival and progression-free survival. And this was above and beyond the standard predictors, which would be age, gender, and gross total resection status, which are kind of the main things that usually predict survival. So knowing the volume of actual cellular tumor went above and beyond the standard metrics. Okay. Anybody have any questions on that before I move on? Okay, great. Okay, so I'm just going to shift gears into NeuroAlign CT and show you mostly more of a case-based demonstration, but give you kind of a first overview. So a NeuroAlign is an FDA-cleared image solution for head CT, and the main thing that it does is to automatically register each of the head CTs to an atlas, and then if you have a prior, you do the registration to the atlas and you do a subtraction map to visualize changes between the prior and the current. So some of the things that it does overall is it does standardize patient positioning and viewing to make symmetry more easier to compare. The patients often will have their head tilted, and again, it supports the conspicuity of detecting changes over time, and then also changing. Well, as you'll see, different things you can assess change over time. And there's been some reader studies showing how it actually does, in fact, include your reading efficiency, confidence, and accuracy. In addition, it does take some measurements beyond just the registration and subtraction. It does a midline shift index, a total intracranial volume, a lateral ventricular volume, and then a change in lateral ventricular volumes. So the way that it works, it can integrate with any scanner, any PACS, similar sort of thing. It takes the raw thin slice data, and in most cases, the way that it's been deployed actually is on an on-premise server, and that's mostly because in order to be as fast as possible, it's ideal to be an on-prem server. But it takes the thin slice data and will do the registration, the subtraction, and then send the data back so that it's the subtraction images, the registration images are done before the study is even completed. Okay, so now I'm just going to go through a bunch of example cases. This is just an example of, sometimes it's challenging for patients to lay flat and be in a standard position, to position in the right way. So this patient had excessive kyphosis, and they tried 2 times to kind of put the patient, they were just not able to tolerate it. So that's just one of the standard things that it does. It'll realign it, so it's what you expect to see. Okay, so here's, I'm going to get into more examples of some of the largest utility, which is more of, again, assessing change between 2 time points. So this is the standard format. You have the first scan, second scan. This patient fell down, has a right frontal hematoma. And then as you may be able to see here, there's a small little subdural. But pretty much every patient that comes in that has a bleed, they're going to get a follow-up study or multiple follow-up studies. And that's at a place that's a busy trauma center and stroke center. That's going to be about 1/3 of what you're doing, reading follow-ups. And so the question, of course, is the subdural bigger? Is it smaller? Is there no change? And that's what we're doing quite often. So here we have the standard. Here we have the reformatted. So now that they're aligned up better, and you can see that perhaps the subdural looks a little bit bigger. You're a little more confident that it's the same slice, the same angulation. But what really makes it obvious is once you have that subtraction image. So you can see here, it just really pops out as being white because you're subtracting the second one from the first one. So boom, it's just very easy to see that there's the subdural is increased. So you can be confident about that and move on to the next case. Here's another one, even a more smaller, more subtle subdural right here. And here's the aligned one. Oftentimes when you do this, you have to pull up the 2 scans, try to get them aligned as close as possible, scroll up and down, look at the coronal or the sagittal, continue to play with it. Maybe you make some measurements. Sometimes it takes time to be confident to know whether it's changed or unchanged. But for me and a lot of my partners, one of the first things we do is we just open up the subtraction image. And then you can just instantly see, well, actually this is, because it's dark, the subdural is actually slightly decreasing over time. Here's again just another case where we have a little thalamic hematoma. Again, they're going to scan the patient again. The question is the hematoma increased? Well, again, you might have to look at it in multiple planes and kind of make that assessment or measure it. But with the subtraction image, you can just pull that up, scroll through it, and you can just tell that it's unchanged. Next case. Here's just a few more examples. Again, the changes over time just really pop out. So sometimes if you're a very busy day, you might scroll through something, things get missed. But by having the subtraction image, it'll just quickly pop up if there's a new subarachnoid hemorrhage. We get a lot of very complex trauma patients that have multi-compartmental hemorrhage, and those can be even more challenging to assess change over time, just because it's not just one small bleed, but there's many things going on at once. But just having that subtraction image it allows you to just really quickly see that, well, there's a new shear injury in the brainstem here, new hemorrhage here, and here in this case you can see there's worsened edema. It's darker here, so there's more edema related to this hemorrhagic contusion, and the hemorrhagic contusion itself is also slightly increased. So here is one of the reader studies I was mentioning that we presented at WNRS and is being written up. What we did is we took about 200 cases of intracranial hemorrhage with follow-up. We had 3 different readers look at time 1 and time 2 and come up with an assessment of, is the intracranial hemorrhage increased, decreased, or unchanged. We went to the radiology reports and tried to find the ground truth, and if there was inconsistencies, we had to adjudicate what was truly the ground truth. But what we found, first of all, the average time to read these studies and recorded the amount of time it takes to read it, with NeuroAlign was 71 seconds, unassisted was 98 seconds, so you're saving like 20-30 seconds, and this is just in the assessment of change in intracranial hemorrhage, so it saves you time. We also rated your confidence and how confident you were whether or not there were changes over time, and the confidence, all these categories, there's higher confidence, statistically significant for assessing whether there was change for all 3 readers individually, felt more confident about it. And then also importantly, the final thing is when using NeuroAlign, that you actually were in fact better at detecting change. The sample size is relatively small, but just barely statistically significant. But having NeuroAlign, you're more accurate, picked up more cases with increasing intracranial hemorrhage. Okay, moving on. The other common thing that we do in the inpatient setting is assessing changes in ventricular size. Patients that have, oftentimes if you have intraventricular hemorrhage or a brain tumor, you get a shunt, and the shunt is usually temporary and to prevent hydrocephalus and obstruction, and so they often will try to get the shunt out, so they'll clamp the shunt to see whether or not there is an obstruction or not. So the main task there is to see if their ventricles have increased or decreased. And so that can be also something that's quite time consuming, challenging if you have different orientations, you manually measure it. It can be hard to be confident about whether there is the ventricles have changed or not. But here with NeuroAlign CT, again, here's the standard. Here's the reformat where it's a little easier to see you're in the same plane. And here's the subtraction image. So with this subtraction image, you can kind of really quickly see this kind of dark border around the ventricles, which means that the ventricles have gotten larger because the edges of the ventricles where there was brain is now being replaced by CSF. So quickly just look at the subtraction map and you can say that the ventricles have gotten increased in size. Here's another example here, the standard. The reformats, again, same question, are the ventricles increased, decreased, unchanged? Again, you might have to take some time to measure it. But with the subtraction image, you can quickly see there's a band of white around it, meaning that the ventricles have decreased compared to the prior study. Here's just one more example. Same thing. Are the ventricles increased, decreased, or unchanged? You have the reformats. You have the subtraction image, and there's nothing. There's just standard noise you'd expect, so they're unchanged. And this, looking at the ability of this tool to improve accuracy performance for assessing ventricular size was published previously. One of my colleagues at UCSD, Nikki Farid. And so in this paper that was published several years ago, they found that inter-rater reliability in assessing change was higher and more accurate with NeuroAlign. And it also, again, improved reader confidence. And then also some additional interesting kind of use cases and utility in the tool. I would say the majority of the utility does have to do with more of the inpatient acute setting where you're assessing change over hours, days period of time. But the subtraction tool can also be useful in more of a subacute time frame as well. So this is an example that you have time 1, time 2. Probably wouldn't even notice anything, but with the subtraction image, all of a sudden you see this kind of area of decreased signal. If you look back on the image, it's actually quite hard to see, but and then this patient also got another follow-up, time point 2, time point 3, and then another subtraction image, and it starts to pop out more clearly on time 3. But what it's actually showing is an evolving acute infarct across the 3 different time points. Again, more examples of ischemia here. So we have the standard, the reformat. It's probably not so obvious. I mean, most neurologists would, if they took their time, would see this, that in fact there is some edema, hypoattenuation, left basal ganglia here, time point 1 versus time point 2. But really, the subtraction image helps it pop out quite clearly. That'll do evolving left MCA infarct. This is a more of a kind of like subacute setting. So even after 3 months, the patient comes back, you can do the subtraction between the 3 months ago. And this patient has a lot of white matter disease, lacunar infarcts, kind of busy. It's hard to necessarily easily see a change. But with subtraction images, you can actually really identify that. In fact, this patient has had 2 infarcts in that 3-month period between the 2 time points over 3 months. And so having 2 new infarcts on contralateral sides, actually this suggests that the etiology and this patient is having multiple falls, is likely having a cardiac embolic phenomenon leading to these infarcts. So again, it really just kind of helps identify the changes between the time points, helps make them pop out. And then I think I just have this one final example here, also very subtle finding that kind of popped out that probably would not have been noticed without the NeuroAlign. You have the standard, you have the reformat. It's really nothing that obvious that pops out until you see all of a sudden the subtraction image. Now sometimes there's noise, but what you can see is that there clearly is a change. There's decreasing attenuation right here, which it corresponds to the hippocampus here, and then the left occipital lobe. And so if you have this is kind of within kind of left PCA distribution. This patient had some visual symptoms, and here's actually the diffusion from the MRI. And in fact, this was a new acute subacute infarct in the PCA distribution that was kind of brought out more clearly just from that subtraction image. So that's all I had to present. Just a reminder of the other kind of suite of products in the Cortex.ai Neuro Suite. So yeah, thank you so much.